I'm going to talk to you today about an ethical question that arises for policymakers who have to decide how to spend scarce healthcare dollars on global health. This is the question about how to identify the group that is the worst off. I've already realized in this room that since all of you are sitting happily eating pizza, I'm not. I am clearly the person who is the worst off at the moment. I don't think I get any claims as a result, unfortunately. So what I'm going to do, I'm going to start off by showing that there really is a big problem here, a problem with making hard decisions about how to spend money on global health. And I'm going to briefly outline one way that people have tried to make those decisions through cost-effectiveness analysis, and suggest a problem with that way of allocating resources. And I'll suggest that the idea of giving priority to the worst off is one way to solve the problems there. And then what I want to do is to try to answer the question, what sort of conception of disadvantage should we be using when we're identifying who the people are who are worst off? Before I say anything else, I have to give you this disclaimer that these are my views, they're not views of any part of the US government. These views on prioritarianism are not necessarily the same as the Obama's views on prioritarianism. They are, however, the views of my co-author, Daniel Sharp. Hopefully, any of the sound arguments I make, you can attribute to him. Any fallacies I commit today, you can attribute to me. So, start with the question of scarcity in global health. Funding for global health has grown enormously over the last decade. So looking at just US federal government funding for global health, it's increased from about $1.7 billion in 2001 to nearly $9 billion 10 years later. But the money that is spent on healthcare by international donors and by national governments is nevertheless dwarfed by people's urgent health needs. I can illustrate this with one example, which is treatment with antiretrovirals for HIV/AIDS. Now, there's been a massive global effort to stem the AIDS epidemic over the last 10-15 years. More than half of US aid for global health has gone on treatment for AIDS. And as a result, there are millions of people who are now receiving life-saving treatment. This is a graph that shows the gap between people who are on antiretroviral therapy for HIV/AIDS and people who are eligible for antiretroviral therapy according to the WHO guidance, and broken up by region of the world. My worries about whether or not you'll be able to read the small print on the slides have been really ameliorated by the vast screen that I'm standing in front of. So you can see here we have millions of people on antiretroviral therapy. This is actually a huge success, especially if you look back at a decade or more ago when people were very skeptical about the possibility of actually getting treatment to people who needed it. But nevertheless, this is an enormous gap. And the 15 million people here who are identified as being in need of antiretroviral therapy, that is eligible now for treatment, are just a fraction of the 35 million people who are currently living infected with HIV. So, despite the enormous amounts invested into HIV/AIDS treatment, there's still a gap. This is what UNAIDS say in their most recent gap report. They say the significant need for AIDS investment requires that in the coming years, both domestic and international funding must not only be sustained, but also steadily increased to meet the 2030 targets. But global health funding has flatlined. So US government funding, for example, peaked at about $9 billion. Over the last 5 years, has remained flat or slightly diminished. And of course, antiretroviral therapy just happens to be the most prominent and the largest recipient of global health aid. It's not the only thing we could be usefully spending money on. Right? There are people who are dying from malaria, from diarrheal diseases, women dying in childbirth because they don't have facilities with skilled attendants there, children not making it to school because of nutritional deficiencies, minimal or non-existent cancer screening programs, epidemic of obesity, diabetes, stroke, heart disease, and so on. This is not going to be a cheerful session, just to lay that out now. There are all these health needs, and we know that there is effective care that can be given to help people with these needs. It's not a matter of not knowing. So, what people need, what we know would help them far outstrips the resources that are available for them. In the face of this, right, in the face of having needs that are unmet and having limited resources for those needs, policymakers who are deciding how to spend scarce healthcare dollars on global health have got to make hard decisions. And they can make these decisions either, as it were, without saying what it is that they're doing, trusting their guts, or they can make them according to explicit principles for allocation. In which case, they can make them according to principles that can be justified to the people who are affected. And unsurprisingly, I think that that's what they ought to be doing. And that's what I want to be talking about. So, if we're going to make a principled decision about how to spend scarce resources on health, how should we go about doing it? Well, one way is to look at the different options we have available, different ways we can spend money, and to assess how cost-effective each of the options is. So some of you here will be familiar with quality-adjusted life years and disability-adjusted life years, QALYs and DALYs. These are summary measures of health. Basically, they provide a common unit of measurement, a common unit of either how healthy someone is or how diseased they are. That allows us to compare how healthy people are in different states. So compare how bad it is for someone to be blind, how bad it is for them to have a period of depression or be in pain or whatever it might be. One QALY, on quality-adjusted life year, is the equivalent of 1 year of healthy life. And a year spent in less than perfect health will then be worth less than 1 QALY. Okay, so if we think that being in chronic pain due to osteoarthritis reduces your health-related quality of life to 0.8, then a year spent with osteoarthritis will be worth 0.8 QALYs. And if we cure someone of that, or relieve their pain, then we will gain from that 0.2 QALYs for each year that they then live without pain. DALYs, just for your interest, DALYs are like the mirror image of QALYs. So DALYs are a measure of how much disease there is in the population. QALYs are good, we want more of them. DALYs are bad, we want fewer of them. Okay, so given sufficient data, we can evaluate the cost effectiveness of a spending decision by looking at the QALYs per dollar gained or the DALYs per dollar averted. And so we can then compare different options this way. Now, some people, including a lot of economists, think that once we know the most cost-effective option, that then tells us what we should do. But cost-effectiveness, though obviously relevant to priority-setting decisions, to decisions about how to spend money, cost-effectiveness is not the only thing that matters. We should also care about how the benefits get distributed. So to give one simple illustration of this, it's often the case that when we're allocating resources for health, thinking about, for example, rolling out some new vaccination program, it's often the case that it's going to be cheaper to provide the health benefits to people who live in cities than people who live in the countryside. And this is just a function of where people are located, how easy it is to communicate with people, how easy it is to get resources to people, and so on. But it's also the case in most low and middle income country cities, you're better off being in a city we just went on cost effectiveness, we would end up giving more to the people who already have more. And a lot of people think that that's ethically problematic. That seems like it's unfair. So one common alternative to straight-up maximizing using cost-effectiveness analysis is a view that is called Prioritarianism. And this is a way of trying to incorporate concerns that people have about how the benefits that we're distributing, how the benefits we're distributing are going to be spread around people. So according to Prioritarianism, the worse off someone is, the more important it is to benefit that person. And so this view tells us we should care about how much better it seems. We should also care about how badly off that person would be if they didn't receive the benefit. So according to Derek Parfit, the strength of our reasons to benefit people depend both on the size of these possible benefits and on how well off these people are. And this view is often encapsulated in the slogan, priority to the worst off. But prioritarianism is not just a view that's held by academics. A number of researchers have surveyed lay subjects and asked them about their view about how important it is to provide benefits to people who start at different baselines. So this is an example of that. So just looking at health benefits. Don't worry about these numbers here for a moment. Let me just talk you through what this table shows. So basically people were asked how much value they would assign to providing benefits, health benefits to people. And the people who were going to be benefited would start in different states. You could be dead, you could be completely disabled meaning completely bedridden, all the way up to slight disability, which means you can move around freely, but walking more than 2 kilometers is a challenge. Now, crucial thing here, each of these stages, going from 7 to 6, going from 5 to 4, and so on, each of those improvements was evaluated as providing the same amount of benefit. Okay. Now, people were asked to say how important it was to provide the benefit to people who started off in each of these states. One was the biggest, the largest value. So if instead of someone being dead, they could instead be in perfect health, that gives you a value of 1. Okay. Now what I want you to look at is this diagonal line here. So this diagonal line tells you how much importance was assigned to moving someone up an equivalent amount of benefit, but starting at a different point. Right, and you see the importance that people attached to moving someone from a state where they would be dead to a state where they would be completely disabled to point 4, and then we get diminishing amounts of value assigned to each of these. So most people think it's pretty trivial to move someone from a state of slight disability to being healthy, right, in comparison to an equivalent sized gain to someone who was really badly off to begin with. These results have been replicated in various different populations in various different countries. Okay. Now, philosophers and mental ethicists often talk about prioritarianism. They often talk about this idea of priority to the worst off. They don't often say what it is they mean by the worst off. But if we're going to put prioritarianism into practice, as I think we should, we need to first identify who the worst off people are, and then identify what health conditions are they suffer from, in order that we can give those conditions priority. Now, the reason that this is challenging is that there are various ways in which people can be badly off. So, let me illustrate this with a rather idealized case. Idealized in the sense of being unrealistic, not in the sense of being good. So suppose that we have to make a decision about the allocation of scarce resources. Pick a very specific resource, say that we have a kidney for transplantation, and we have 3 people, and those 3 people would benefit equally from receiving the kidney. So whatever life span we already have would be extended another 10 years in reasonable health. Okay, and then we ask, okay, so why should we give it to one of these people rather than another? And just for the sake of it, we've got to imagine people are advocating for themselves. Right? So the first one says, well, I'm in agony for my disease. I have congestive heart failure. If I don't get the kidney, I'm going to die very soon. It's really important that I should get the kidney. Right? And the second says, okay, it's all very well. His need is urgent. But he's already had a long life. I'm much younger than he is, even though my disease is not as severe right now. I can have a much shorter life if I don't get it. And the third one says, typical, you let the men speak first. See, my disease may not be as bad as theirs, but I've been disadvantaged my whole life. My parents sent my brothers to school and kept me at home. That's all they could afford. I get discriminated against when I try to get work. My health may not be as bad, but I'm disadvantaged in all sorts of different ways. Okay, so this admittedly very idealized case suggests 3 important questions that we have to answer if we're going to say what it means to be badly off for the purposes of allocating health resources. Right. First question, should we prioritize urgent need? That is, if someone is sick now, we could help them now. Is that something that we should be taking into account? Second, is a shorter life worse? That is, if we look at someone's life overall, not just at the benefit that we might give them, are they worse off if their life would be shorter? And third, should we care about more than just health? There are lots of ways of being disadvantaged other than being unhealthy. Right? Someone can be economically poor, they can lack education, they can not have safe housing, they can not be physically secure, they can be discriminated against for jobs, they can not be allowed to practice their religion. Do we count all of these when we're distributing health resources, or do we just care about people's health? Now, I can argue for what I think are the right answers to these questions, and that will give us a conception of disadvantage, a conception of being badly off, that will allow us to pick out the worst off. And then we're going to use that conception to draw one implication about spending decisions. You already have it?
Is there some kind of universal standard or governing body that sets a universal standard for how the quality of life is defined, or no?
That is a good question, but I think we should come back to it in the question period, because it will take quite a while for me to answer it. The short answer is no.
Okay.
The longer answer is there are lots of really interesting questions about how to work out quality of life, even just in the health sphere. But they're sort of tricky conceptual questions. Okay, so I'm going to start with the first of these questions, whether we should prioritize urgent need. So consider the following case. You have to decide which of 2 people to treat. Both are in pain due to some terrible injury. You only have one analgesic to give and must decide between them. C suffered from chronic pain for many years, and her pain now is considerable. In contrast, D has never suffered such pain before, but his current pain is far worse than C's. Okay, so C, overall in her life, will be worse off, but D has this episode right now of really terrible pain. And some people think it's counterintuitive to say that we should treat C rather than D. Urgency, for some people, seems like it should take precedence. And Francis Cam, a moral philosopher at Harvard, has exactly this view. Erik Nord, who is a Norwegian health economist who was responsible for the data I showed you in that table before, he has a related view. He thinks that what we should care about is just people's present situation and their future, how badly they'll be in the future. And he thinks that because he regards the past as sunk costs. There's nothing we can do about the past, so disadvantage them is a sunk cost. Okay, so both of these views privilege the present and future over the past. But I think that they're mistaken. I think we should take a lifetime view instead. And we should say that what matters is the amount of disadvantage over someone's whole life. I'm going to give you two arguments for why I think that. First, think about the way that we plan our lives. The disadvantage at one time we think can be compensated for by an advantage at another time. So someone might take further shifts at an unpleasant job because they want to be able to invest more for a more comfortable retirement. Right? Or interpersonally, if my brother got to ride shotgun yesterday, I can say that's a reason why I should be allowed to ride shotgun today. Right? We think that one thing can compensate for another. This is the whole idea of certain forms of compensation, right? We think that something bad that happens to someone can be compensated for by giving them something now, by trying to make them whole again now. But if we can trade off these things, if we trade off being better off and worse off at different times, in our own lives and interpersonally in wider society, then this implies that assessment of someone's claim at a time depends on how well or badly off she is at different times in her life. Okay, second argument is based on an idea of temporal neutrality. So take someone who was aged 25 in the year 2000, and they were really happy then. It was a good year. Right? Now, take someone who is now 25 in 2015 and really happy now. The happiness for the first person, the happiness for the second person seem like they're equally good for the people who experienced them. Likewise, a year of chronic illness in the past, a year of chronic illness now, seems like they will be, at the time that they happen, equally bad for people. Now, it's true that we can't affect the past. Right? But that's not the question. The question isn't what can we affect, the question is who overall is worse off. And it seems to me that this sort of argument, these intuitive considerations suggest that it doesn't matter how someone's disadvantage is related to the present moment. But if benefits matter equivalently over time, if it's just as good to be 25 and happy in the year 2000 and 25 and happy in the year 2015, then it would be misguided to prefer one time to another time. Which suggests that we should evaluate who is worst off by considering their life from a temporally neutral standpoint. Okay, so I think we shouldn't be biased in favor of the present and the future. We should evaluate people's lives by how they are over the whole period of their own life. Okay, second question, is a shorter life worse? Now, I'm hoping that this one is going to be straightforward. That is, I'm hoping even if you disagree with everything else I say, you'll be on board with this one. But in combination with the answer to the first question, it's going to turn out that this is really an important consideration. So I want to just talk it through. We know we have some conditions like osteoarthritis that cause significant morbidity. They don't cause much mortality. We know there are some conditions where the majority of the burden caused by those conditions is in terms of mortality. So malaria, for example, the majority of the burden there is mortality. We want to know how we should compare these forms of disadvantage. So take two people who lead lives basically the same life up till age 20, then one of them dies, the other one goes on to age 80. Seems pretty clear that if you're going to choose which one to be, you want to be the one who lives to age 80, right? The one who dies at age 20 is worse off. So it matters how well or badly someone's life goes while she's alive. It matters how long she gets to live. And we can see that both of these factors matter by the way that we're willing to trade off one for the other. Right? So people will risk death in order to achieve things that they think are valuable. And people climb Everest, I think they're crazy. People climb Everest and they think this is an important thing, even though there's a risk of death. And people go the other way, right? They deny themselves good things in order to live longer. So I quit smoking, and I love smoking. But I quit it because it causes cancer, as it told me on the cigarette packet for a decade. I don't learn quickly, eventually, right? So we want to take into account quality and quantity of life when we're assessing how badly off someone is. Now, the summary measures of health that I mentioned before, QALYs and DALYs, already do this. So for a QALY, one QALY is 1 year of full health. A fraction of that is a year in a state of illness, and 0 QALYs is what you get if you're dead. And we can represent what's going on here, if we want to, with a graph for each individual. So we can plot a graph like this. And so we have age at the bottom here and how healthy they are going up the y-axis here. This is a graph of the life of someone who starts off. They spend their childhood completely healthy. They then experience a period of chronic illness, which substantially reduces their quality of life. They mostly recover and spend time again in nearly perfect health, and then they decline and die at the age of 70. Okay? Now, if we think that we can represent someone's health history like this, and we think that I'm right about how quality and quantity of life should be related, then we can assess how badly off or how well off someone is by just taking the area under this graph. Right? So that will give us their degree of advantage or disadvantage. This will turn out to be important, I promise. Okay, third question. Should we count more than just health? So far, I've just been talking about ways of being well or badly off that involve ill health and death. But there's more to being disadvantaged, more to being badly off than just being deprived of health and life. Right? So your life goes worse if you experience economic hardship. It goes worse if you lack access to education. It goes worse if your civil and political rights are denied you. And this is because there are important conditions. Autonomy, close relationships, knowledge, happiness, and so on, which make your life go better or worse, independent of their connection to your health. We can't reduce the value of those goods, I think, to health, and people are often deprived of them by non-health factors, so like poverty or like physical coercion. But when we're allocating resources to health, should we then take those factors into account, or should we not? Now, the view that only health should be considered when we're distributing health benefits, we've called health exceptionalism. And this is a view that's actually widely adopted by people who work on how to set priorities for health spending. So, for example, DALYs are calculated as a function of years of healthy life lost and years lived with disability. And according to Christopher Murray, who's the architect of the DALY, DALYs are an absolute measure of health loss. Likewise with QALYs, they're supposed to be measures of health-related quality of life. I'm going to argue that this view is mistaken, if you couldn't tell already by the fact that I call it health exceptionalism. Okay, so two main arguments that have been given for why we should be health exceptionalists, that is, why we should only consider health. One of them is based on the fundamental importance of health, and one of them is based on an idea of sectoral justice. I'm going to go through each of them in turn and say why I think they're mistaken, and then give some further argument for why I think it's actually really important not to just focus on health, even when we're distributing resources to health. So the argument from the fundamental importance of health says basically, health is incredibly important for attaining all sorts of other important goods, and that's the reason why health should get a special sort of priority. Now, one problem with this argument, obviously, is that although health is really important for getting all sorts of goods, that's not unique to health. Right? So money is also really important for getting all sorts of goods. If you're economically poor, you are really disadvantaged in all sorts of areas of your life. But the sort of more fundamental problem is that even showing that health is really important wouldn't be enough to ground health exceptionalism. What the health health exceptionist needs is to show that health is so important that we can't ever trade it off for other goods. That's why we're only going to concentrate on health. And that's clearly implausible. Right? We often make what seem to be reasonable trade-offs between health and other values. I might prefer, for example, to die at home with my loved ones rather than die in the hospital, even if being in the hospital means that my pain is better managed and that I live for longer. That can be a perfectly reasonable trade-off to make. So we should reject that first argument for health exceptionalism. The second argument is based on an idea of sectoral justice. Sectoral here meaning to do with sectors. I'm not sure whether sectoral is actually a word, but it's the one that gets used. So sectoral to do with sectors. And the idea is that different institutions and different agents who have certain roles are supposed to promote very specific ends, and they should just promote those ends. So the Ministry of Health should just be promoting health. The Ministry of Education should just be promoting education, and so on. Now, if that's true, then it makes perfect sense why we would only focus on health when we're setting priorities for health spending. Okay, two problems with this argument too. The first is that for the purposes of identifying the worst off, the argument is actually invalid. It wouldn't follow simply from the fact that the Ministry of Health ought only to be focusing on health outcomes, that the Ministry of Health should decide who the worst off are just by looking at the health of the people that are in the population. And it could be you identify who the worst off are through some neutral procedure, and then if you're the Ministry of Health, you give greatest priority to the health of that set of worst off people. So that's one problem. The other is that it seems implausible to think that the sole aim of healthcare itself is to maximize health. It seems like people make decisions that are related to healthcare that don't maximize health. And it seems like physicians can and should be involved in those decisions. And it's not just people saying, I don't want healthcare, I want something else. They can make these decisions with their physicians. So you can make decisions that you want to decline pain medication because you want to be better able to communicate, for example. You can make the decision that you want to go to hospice care before your treatment options are exhausted because you value the specific quality of life you'll get there. But if health is not the only end of healthcare that physicians and patients reasonably consider when they're making decisions, it seems strange to think that it's the only end that policymakers should consider when they're allocating resources for health. This is what Dan Brock says about this. He says, if health is not all that properly guides physicians and patients' evaluation and choices of healthcare, then we cannot simply insist on separate spheres to rule out consideration of non-health effects in other contexts of healthcare choice and resource prioritization. Now, you might think that's all very well, but look, this is an argument about the physician-patient relationship. Maybe there are different norms that go on here. We do also often make decisions at the policy level that are about healthcare and seem to incorporate more than just health. So, for example, one of the major reasons for trying to provide universal health insurance is not actually providing healthcare to everyone. It's providing the financial protection you get from providing healthcare to everyone. So this is a quote from President Johnson on the signing of the Medicare Act in 1965. He said, "No longer will older Americans be denied the healing miracle of modern medicine. No longer will illness crush and destroy the savings that they have so carefully put away over a lifetime so that they might enjoy dignity in their later years. No longer will young families see their own incomes and their own hopes eaten away simply because they're carrying out the deep moral obligations to their parents and to their uncles and their aunts." What's the end of healthcare here? The end of healthcare here is to make sure that people aren't financially ruined by having to pay for healthcare. Also, it's incredibly hard to find a picture of Lyndon Johnson where he's smiling. Literally the only a further argument for why physicians and patients and policymakers shouldn't focus just on health when making decisions about healthcare. And this is to do with the value of health. When we measure health states, we're not actually interested in some pure measure of health. What we're interested in is the value of those health states. In fact, I think it's hard to know how we would go about quantifying an amount of health if we didn't already have an idea about the value of the health. But how valuable equivalent health states are to different people depends on other aspects of those people's lives. And this is because health isn't just valuable for its own sake. It's valuable because of its impact on other aspects of advantage. This is John Broome making this point. He says, the way in which a person's well-being is affected by the various elements of her health depends a great deal on other features of her life. For example, asthma is less bad if you're well housed, mental handicap less bad in supportive communities, less bad if you have access to the internet. The idea presumably being that you can have a reader that can read the text to you in a way that you wouldn't have if you didn't have access to the internet. Okay, so what this suggests is that people who are badly off in other dimensions of their lives, non-health dimensions, are going to be more disadvantaged by equivalent health states. And so that gives us a reason to think about what a person's environment is like, what other disadvantages she experiences when we're assessing how badly off she is for the purposes of allocating healthcare. Okay, so to summarize the conclusions I've argued for here, I think the worst off are the people who have the greatest total lifetime disadvantage. I think lost health and well-being due to premature death should be treated the same way as other losses due to illness. And I think we should count all forms of disadvantage, not just disadvantage that relates to health. In brief, we should adopt what we call the total advantage view. It says the worst off are those who would have the greatest total lifetime disadvantage without intervention. And all else being equal, these are the people who should get greatest priority. Okay, that's what we think is the right view of disadvantage for working out who the worst off are when we're allocating healthcare resources. I want to close by drawing out one implication of this view for the current debate about global health spending. Start by seeing that one direct implication of the view is that people who die very young are almost always among the worst off. To see this, compare someone who dies age 5 and someone who dies age 50. Right? Suppose, to make it as hard as possible, suppose that the person who died at age 5 is in perfect health. I'm just going to talk about health for the moment. In perfect health until she dies. Now, in order for the 50-year-old to be as badly off in his life, he would then, in order for the area of the 50-year-old to have to be the same as the area here, he would have to be in a state of illness throughout his 50 years of 0.1. Right? But if you look at the values that are given to different states of illness people can be in, basically no states are rated as bad as this. The very worst, things like being in periods of acute schizophrenia or very severe multiple sclerosis, maybe come down to 0.3 or 0.2. You might get down as bad as this in the end stages of a terrible terminal illness. Basically, no one is in this state for 50 years. So, pretty much no one is going to be as badly off if they die at age 50 as they would be if they died at age 5. Now, you might think, well, you're just talking about health here. What about the non-health factors that I just argued are important? But I think that those are not going to change this conclusion. One reason for thinking that is that if we had values for those non-health factors, we might expect them to follow pretty similar patterns. That is, it would be very unlikely that people's lives in poverty would be rated so close to being dead. But the more important one is just that the people we're talking about here, the people who are dying at age 5, are already, for the most part, really deprived in other areas as well. The 99% of under 5 deaths occur in low and middle income countries. We're not going to be comparing people who die age 5 really rich with people who are dying age 50 really disadvantaged in other areas. So, if we're identifying the health conditions affecting the globally worst off, we should look first at the conditions of people who die as infants and children, and maybe adolescents and young adults in conditions of severe deprivation. Now, this conclusion is really important for a discussion that's going on at the moment about how global health funding should respond to a recent shift in the global burden of disease. So over the last few decades, there's been this epidemiological transition in low and middle income countries from the communicable diseases that used to be responsible for the majority of the burden of disease. Malaria, diarrheal diseases, HIV/AIDS, also neonatal conditions, various nutritional disorders. Been a shift from those being the major contributors to the global burden of disease to what are called non-communicable conditions. Diabetes, cancer, stroke, heart disease, depression. These are now responsible for the majority of the burden of disease. And so, many people argue, maybe these conditions should be much higher on the policy agenda. Maybe we should be shifting funds to combat those rather than sticking with communicable diseases. So this is the WHO's Global Status Report on Non-Communicable Diseases from 2010. They say, non-communicable diseases, NCDs, are the leading global causes of death, causing more deaths than all other causes combined, and they strike hardest at the world's low and middle income populations. So it's natural to ask, should we be redirecting resources from treating and preventing infectious diseases to treating and preventing chronic diseases, the sorts of diseases that they're concerned with here? The usually implicit assumption that what we should be doing is trying to minimize preventable deaths or to maximize qualities says yes, we should be shifting funding that way. If you're a prioritarian, if you think we should give priority to the worst off, I think the answer remains no. Okay, take a look at this graph. This is from the Institute for Health Metrics and Evaluation. Don't worry about the key here for the moment. This graph is showing you for sub-Saharan Africa the number of deaths on the y-axis and the age of the decedent on the x-axis. Right here, this is the first week of life, first month, first year, 1 to 4 years, and then in 5-year increments. And so, what we're talking about here, these are absolute numbers on the side here. So, what we're talking about here is millions of child deaths. Point 1, the class of the worst off is still very, very large. For your interest, just so you can see the difference in the pattern, this is what the same graph looks like for the European Union. Quite amazing, isn't it? And then the equivalent one, in case you're curious, for the US. Changing in the absolute numbers on the y-axis there. Okay, back to sub-Saharan Africa. The class of the worst off is clear. The question then is what this group is dying of. And if you blow up this left-hand side of the graph, you can see what they're dying of. And it's diarrheal diseases, lower respiratory infections, neonatal conditions, nutritional disorders, a little malaria, a little later in life, people start to die of HIV/AIDS. This suggests that we shouldn't be shifting resources away from those diseases, from communicable diseases, neonatal conditions, nutritional deficiencies, to communicable diseases, to non-communicable diseases. Because the non-communicable diseases are not affecting the people who are worst off. Now, a caveat, of course, this conclusion doesn't follow simply from those being considerations of cost and quantity of benefit are still relevant. Right? Recall the original discussion of prioritarianism. What we care about is both how badly off someone is when we can benefit them, and how much benefit we give to them. But the cost of preventing or treating most of these conditions is very low. So oral rehydration therapy, anti-malarial drugs, insecticide-treated bed nets, nutritional supplementation, even now antiretroviral therapy, relatively speaking, are cheap, and they provide a huge benefit. Right? They provide a huge benefit because they save the people who survive all these years of life into adulthood. So, it seems to me, we have strong reasons to keep communicable diseases and child mortality a high priority. Okay, so I've argued that in the face of having to make hard decisions about how to spend scarce money on global health, policymakers should be prioritarians. They should give priority to the worst off. I've argued for a specific conception of what it means to be badly off, what we call the total advantage view. That the worst off, so those who should get highest priority, or else being equal, are those who enjoy the least lifetime disadvantage, where that includes more than just health. Includes information about other ways in which people can be deprived as well. This suggests that the worst off globally are children who die young. And these people are primarily suffering from communicable diseases, diarrheal diseases, malaria, HIV, and so on. And so those are the conditions that we should still be focusing on if we want to be prioritarians in our spending on global health. Thank you.
The floor is open. That was perfectly timed. It's 1 o'clock.
Yeah.
I blog about public health topics, so I'm specifically interested in the intersection of public health and then the economic piece. Like, you say, economics, like decisions are being made about how you decide what resources you're supposed to allocate to any specific place. What is the standard? Like, what standard are they using to measure what you're talking about? Does that standard apply to some universal scale? Does that kind of thinking come from the United Nations, or World Health Organization, or is this like a small community of people that approach public health from that standpoint?
So there is no agreed on standard for any of this, how we should be making decisions or what measures we should be using in making those decisions. I think a lot of people think that we should give greater priority to the worst off. Like the saying that priority to the worst off is a slogan is supposed to be taken literally. A lot of people say that. And then people will pick on, depending on what they're advocating for, will pick on different ways in which people can be disadvantaged to argue for the particular diseases that they should think should be given priority. But none of this is officially endorsed by anyone. So my caveat at the beginning, my disclaimer at the beginning would also be these are not the views of any official body. Other questions? Please.
Will your analysis change at all if this was not global health, but health for an individual country or other body allocating scarce resources?
Yeah, good question. So the theoretical part would remain the same, right? The conception of who the worst off are remain the same. What changes is which group then gets picked out by that conception. And I think that the global health context is actually the easiest one to handle, because everything converges. You have a huge burden of child mortality, and that's happening among the most deprived sectors of the population. So it's easy to say, oh, and also it's really cheap to intervene, right? Move it to a country that is dealt more or less with child mortality. Right? So when child mortality is down in around 5 or 10 per 1,000. Well, then it becomes really hard, because you have to bounce off different has schizophrenia, and they spend their whole life with schizophrenia. Maybe they live twice as long as the young adult who dies in a car accident. But it may be they're equivalently better now. It seems to me, once we get out of the child mortality, it becomes really hard because you need to know exactly how bad each of these deprivations is. Right? Now we need the weights to say, okay, how bad is it really to have these illnesses? How bad really is it to be economically poor or to be discriminated against? And those are really hard questions. Yeah.
I'm curious how you view the role of individuals who have some instrumental impact on the well-being of others in a disproportionate way.
You want to give an example?
Well, there are a variety of examples. There are people who are the sole wage earner or a household of 7 people. There are people who are the emotional glue that's holding together a variety of people who have less mental stability. There are people who, if you counted the domino effects, the cumulative disadvantage that would be prevented by aiding that instrumental person would be larger than the cumulative effect from treating someone else who didn't have that kind of domino impact. But not when you look at it only on the individual level.
Yeah, great. So the really short answer is I think we should be counting those indirect benefits just in the same way that we would count the direct benefits. So if you're the sole wage earner of the family, and say you're suffering from tuberculosis, we want to know, well, should people who are wage earners be given priority because of the people they support? I think we can ask the question, well, how disadvantaged are the people they support? What would happen without them there? And on the basis of how important that is, you could argue that the wage earner should be given greater priority. Now, the danger is, of course, that you risk forms of amplifying disadvantage. Right? That people who are badly off and therefore no one is dependent on them end up getting treated worse. That seems to me to be the balance. This is like the case, people talk about special responsibilities. And they say, I have special duties to my family, and so I should privilege my family. And someone else says, well, I don't have a family, so I guess I don't have special responsibilities to them, and they don't have special responsibilities to me. So I miss out on all these benefits of having a family. And now you're saying, because this person has a family, they should also get higher priority because they're going to benefit their family. And that looks like it might be problematic. Am I answering your question?
Mm-hmm. So a little bit of a follow-on to that, and a little bit probing on this NCD shift. Let's assume that children are still your priority, and you want to reduce morbidity and mortality. But if the caregivers that are there, that are really supporting them, are suffering from a completely different set of burdens of disease and setting, I mean, it's not going to do much good for those under 5 kids if they have no parents by the time they reach age 5, even if you prevent all of the diarrheal disease. So how do you sort of balance those commitments, recognizing that it's not just getting them past these sort of very critical acute illnesses, but protect their life course and their capability?
Yeah, I mean, just to emphasize the first part of my response to Nancy there, I think we can count those indirect benefits, right? Suppose that we're thinking about parent-child pairs where the parent has HIV, right? It might be that the best way to help the child is by providing the parent with antiretroviral therapy. And that, to me, if that is genuinely the best way to do it, then it seems to me that's perfectly justified. I just think we have to be very careful about the details of the cases, which way we go on that, in order that we're not amplifying already unjust situations. HIV seems to be a case where this happens not infrequently. HIV, TB, that set of diseases diseases. I'm not sure the extent to which it happens with other chronic diseases. So it'd be interesting to see. Yeah,
Or
what do
even
you
if
know?
it was the financial protection piece.
Yeah.
They're going to be severely impoverished by whatever, the
Yeah.
wage earners riding or the illnesses they have. Then that's also going to be really bad for the prospects of the children.
Yeah, that's perfect. But if that were actually what happened, I would be on board with the conclusion. I just want to be cautious about making sure we've got the empirical facts right on those sorts of cases. Having a sick child can also be financially very bad, right? And then you miss work, then you have to pay for the child to be treated, etc., etc. So there are considerations involved on both sides. Go on, Travis.
So I have a question about the graph that had a lot of clustering at the very, very early ages and then a shift in diseases after age 4 or something, right?
Yeah.
Yeah. So I can imagine thinking that priority or that dying at a young age seems very, very badly off up to a certain level of youth, at which point you think that because they're not sufficiently autonomous yet or not sufficiently kind of philosophically robust agents, that there's actually less badness there. So I could imagine thinking that 15-year-olds and 20-year-olds dying have all of the badness of losing their future, right? And they're much more people than 5-year-olds or 3-year-olds or 2-year-olds or something, right? So I guess I'm not able to absorb the whole graph, so I wonder if you had some kind of inclination like this, which I know some philosophers have, if that would shift your conclusion. So if the diseases that bunch up, 5 to 9, 10 to 12, 15 to 19, 20 to 24 are really quite different from the diseases that bunch up as 0 to 4.
Yeah. So some people, including me actually, have the view that very young deaths are not as bad for the person who dies as older deaths. And the explanation for that is normally connected to the cognitive development of the person who dies. The idea is that a neonate is not very connected to her future life. Doesn't have self-consciousness, she doesn't have the idea of herself as a being extended through time, she doesn't have an idea of the future and so on. So some people think that that suggests that losing that future is not as bad for her as it would be for, say, a 15-year-old. Right? Now, if you have that view, then you're going to say, these deaths down here are not as bad for the person who dies as these ones here. And then there'll be an open question about where here the early deaths start to be as bad as the late deaths. So I'd say two things. I'm sort of largely in sympathy with this, but two things. One is that in terms of who is the worst off, I think the argument still goes through. The badness of death is about the size of the benefit that you get from saving someone's life, not about how badly off the person is who dies. Okay. Now that's basically a philosophical point, but I think it's good to keep these things distinct. The other is that I think if you take seriously people who have argued this view and what they say is important in order for your death to be bad for you, the time where death is worst is going to be relatively early on. Maybe as early as 2, definitely by the age of 5. Right? Unless you're going to be really snobbish about what you think it is that matters, right? Which is going to rule out a lot of people as not leading lives that are worth having, then you've got to say it's relatively early in childhood. But this is why it's such an interesting point, I think. That changes quite a lot what the diseases are we should be concerned about. If you're saying 5-year-olds are the worst deaths, then things like malaria and diarrheal diseases are still big killers. If you say 15-year-olds, that's no longer true. Then you're into thinking, well, it's HIV, it's violence, it's accidents, these sorts of things. So that is going to make a huge difference to who counts as deserving the greatest priority.
Just a follow-up on that, something makes me uncomfortable about that.
memory. So, and that's this individualized view of it.
Yeah.
And is that the way we want to look at health in a society? Or do we want to look at sort of the implications for the whole relationship among families and communities, and not just on the health?
So, first of all, I'm not here saying that would be the right way to do it. But on that sort of view, you can still say it's bad for the person that she dies. And the crucial thing is that we're making comparative judgments. We're not saying, you know, should we build an opera house or should we spend money on diarrheal diseases? We are collectively doing that. We shouldn't be doing that, right? On any view, right? What we're saying is, look, if we've got to choose this really hard choice between focusing on this group, who otherwise has really high mortality, or this group has really high mortality, how do we balance those? And there, I think, it becomes more acceptable to say, well, look, some of the times you're really short of resources. It may end up being more important to focus on the 5-year-olds than the neonates.
I mean, just,
So what are,
yeah,
that's sort of
yeah,
philosophically, I think,
Yeah.
how we should analyze it. Now, the signal question is totally different, and I think is also really important, right? What do you think is the right answer in terms of ethical theory is one thing. What would happen if you advocate for it and put it into practice is another. That I'm not qualified to speak on, but I do think it's really important.
well, and maybe just as a footnote on that, I mean, maybe it would be a win-win if we could see so many women dying in childbirth, that if we could do better at that, we might at the same time do better at kids living beyond. You know, the woman dies in childbirth, the baby lives for a few days, then they're dead too.
Investing in maternal health is a win in all sorts of
Yeah,
ways.
so I mean, that may be.
You save women, you save children, not just about the children who would die in childbirth,
But
it reduces child mortality all the way along here. Investing in safer care for